There's a very high impact of arthritis-related conditions. In fact, the CDC estimates that 1 in 3 Americans has some type of arthritis or musculoskeletal disease, and over $8 billion per year is spent on total knee and hip replacements. And unfortunately, this is increasing at a dramatic rate. In fact, it's thought that in 20 or 30 years, there won't actually be enough orthopedic surgeons to do all the joint replacements that may be needed. And so we'll talk about how to prevent that.
Welcome to the Joint Space Podcast, brought to you by the University of Arizona Arthritis Center, one of the first 4 centers of excellence in the University of Arizona College of Medicine, Tucson. The mission of the Arthritis Center is to make a difference in the lives of patients and their families by conducting research ranging from molecules to people, by empowering patients to take charge of their lifestyles, and by educating clinicians and scientists to enable compassionate care and the delivery of novel, effective, and safer therapies. Hello, and welcome to the first episode of the Joint Space Podcast. My name is Tracy Shake, and as Director of Community Outreach and Education at the University of Arizona Arthritis Center, I am excited to introduce our center's new podcast that I have the privilege of hosting. In the show, we explore a wide range of health and wellness topics with some of the most respected experts and brilliant minds who share the latest research, clinical care, treatments, and medical innovations to help patients find new pathways to health and wellness. And there is no better place to start than with our first guest, Dr. Kwoh. One of the most highly regarded and respected rheumatologists in the world, he is internationally recognized for his research on novel imaging biomarkers of knee osteoarthritis. Dr. Kwoh serves as director of the University of Arizona Arthritis Center. He holds the Charles A. L. and Suzanne M. Stevens Endowed Chair in Rheumatology and is chief of the UA Division of Rheumatology. In addition, he serves as professor of medicine and medical imaging in the UA College of Medicine, Tucson. He is internationally recognized in the identification, development, and progression of osteoarthritis and the characterization of pain patterns in OA. He also has a major interest in the reduction and ultimately the elimination of racial disparities in the management of arthritis and musculoskeletal diseases. He has been awarded nearly $11 million from the National Institutes of Health during his tenure at the University of Arizona, with total career funding from the NIH of over $75 million, continuous since 1989. An author of over 300 peer-reviewed publications, he has been awarded numerous honors throughout his 40-year tenure as a rheumatologist. In our conversation, Dr. Kwoh gives a masterclass on everything you should know about joint health and joint pain. We are excited to dive in, so without further ado, here is our conversation with Dr. Kwoh. Dr. Kwoh, you were recently named Master of the American College of Rheumatology at the 2023 conference in San Diego. Can you tell us what it takes to be named as a Master of the ACR?
It's really an accumulation of lifetime achievements based on service to the American College of Rheumatology and other similar organizations, and then accumulated excellence and expertise in research, your academic career, education, and clinical service.
So over your 40-year career, that you've seen a lot of change, I'm sure. And, one of the things that we're interested in is more and more patients are starting to look to the internet to get information about some of the key things that are critical to arthritis. So what we'd like to do is set the record straight here and have an opportunity to talk to you about some of the key terms, have you explain to us what we're looking at when we're talking about arthritis, which encompasses, of course, many different conditions. So if we can start out, we want to start a little bit basic today. And if you can tell us first, what is a joint in the body?
It's interesting you bring up the internet, because in one of my articles early in the career, just as the internet was starting, was actually people didn't know how much, in terms of doctors, how much patients were searching on the internet. And certainly now patients come in with printouts and have, consulted Dr. Google and think they know what's going on. And so, a joint is really where two bones come together in the body. And so there are three types of joints. One where the joints actually fuse and then don't move anymore. So an example of those are like the sutures in your brain, because it's actually composed of a number of different bones. The thought is that maybe there actually is a little bit of motion. They're not totally fused. If one talks to doctors of manipulative medicine, then there are joints that have a little bit of motion, but not really much. And so that's like the two bones in your arm, close to the wrist, in terms they're basically tied together by ligaments. And so there's a little bit of motion there. And the same thing in terms of two bones in your lower leg. And then the joints that people most often think about are what we call synovial joints, that are lined by synovial tissue and the joint capsule. And then there's cartilage, like in your nose or in your ear, but there are different types of cartilage that then help cushion the bones and allow them to move freely mobile.
So you've referenced this, but what's the primary function of joints, of mobility, et cetera? A lot of people that have joint issues as they get older. So what's the primary function, and what needs to be done in general terms to maintain that type of function?
So the joints are really do two things. One is to provide stability, but also movement. And so our bodies are meant to move. So if we are put to bed, we lose tissue in terms of muscle and bone mass. And so we really need to move. And, years ago, when people had more serious illnesses, or let's say joint replacement or heart attacks, people were put in bed for days or even longer. And now we know that that's not a good thing. And so we mobilize people as much as possible. And so keeping your joints moving is good, but also protecting them. So you don't want to put abnormal stress on joints where the biomechanics is, because if you put too much stress or overuse, they can break, but also then cause damage to either the bones or the joints, and the ligaments and the tendons around the joints are what strengthen them. And so if those are overstretched or stressed, as if you get an ankle sprain, then you may have laxity. And so you have loss of that stability within the joint, and that can be a problem. So really, you want to keep moving, but you want to do it in a safe way to protect your joints.
So when we did your introduction and talked about what we were going to discuss today, of course, osteoarthritis was the main focus, something that so many people suffer from. And so what causes osteoarthritis? So we hear wear and tear, strains, injuries, things like that. With your background and your significant background in research of osteoarthritis, what are the primary causes?
So we know that osteoarthritis is actually more than one disease. There's probably different subsets of osteoarthritis. There may be one that's more biomechanical, one that is more inflammatory, and one that is maybe more related to cartilage degeneration, and another that may be related to the bone and abnormal processes within the bone. Now, it doesn't mean that these are all distinct, and individuals may have more than one of these phenotypes, but it's good to think about what may be causing the problems within an individual and what may be predominant, and then the hope is then targeting treatment toward the predominant phenotype that individuals have. In terms of what causes osteoarthritis, we know that there's a number of risk factors. Certainly as one gets older, that's an important risk factor. We know that increases with increasing age. Sex also, hormones do play a role. We know that arthritis, particularly in certain joints, particularly in the knee and the hands, goes up dramatically after menopause in women. And osteoarthritis occurs more often in women than men. Joint injury, trauma certainly is a major risk factor. Surgery that occurs in the joint. We know that there's genetics involved, so it runs in families. And then we know that obesity, overweight, increasing BMI certainly plays a role, both in terms of biomechanically, in terms of the weight on the joints itself, in terms of particularly your knees, but also in terms of hips. We know that it also causes problems in terms of hand OA, and most people don't walk on their hands. And so we know that having obesity and overweight actually can cause subacute inflammation. And inflammation, as we and others have shown, is very important in terms of osteoarthritis, in terms of specific forms of osteoarthritis.
So we can gather that osteoarthritis is one of the most common forms of arthritis. If you can talk a little bit about, the top 3 most common forms and how they differ from one another.
So osteoarthritis is the most common form of arthritis. There are 100 different types of arthritis. Probably osteoarthritis of the knee is the most common, followed by the hip and the hand, but it can affect many other joints, including shoulders, elbows, ankles, and feet. And it's the most common type of what used to be called non-inflammatory arthritis, but as we mentioned, there is inflammation, more low-level inflammation in osteoarthritis. And the most common type of inflammatory arthritis is what people think about as rheumatoid arthritis. Rheumatoid arthritis, again, is a number of different subsets of disease, and people may be seropositive or seronegative and have other different disease manifestations. But the prototype of inflammatory arthritis is red, hot, swollen joints. This is generally the small joints in your hands and feet. So we're talking about in terms of your wrists, your knuckles, and then the joints, just the knuckles closest to your fingernails. But usually it's more the knuckles here, what we call the metacarpophalangeal and the proximal interphalangeal joints. And the third type of arthritis that's probably most common these days, and again increasing with the obesity epidemic, is probably gout. Gout is increasingly prevalent with obesity epidemic, and that's a different type of arthritis caused by a crystal. So it's abnormal metabolism that causes a compound to accumulate within the body and then can cause inflammation.
So we often hear about gout in men. Is gout as common in women, or is that predominantly a male
So
disease?
it's more male predominant. It's rare to see gout in premenopausal women, but generally occurs after menopause. And so again, seems to be a hormonal component that may play a role there. So it is more predominant in men, but certainly can occur in women after menopause.
And so you talked about osteoarthritis and predisposition for that and some causes. With rheumatoid arthritis and gout, how much of a genetic component is there? We've talked about obesity being an issue. What are the other causes for rheumatoid arthritis and or gout?
So gout is it's a metabolic problem, but it's also genetic because that can run in families. There can be specific genetic disorders in terms of single genes that may be involved, rarely that cause certain subsets of gout that may be quite severe. And so one can see that in families. And so if you have a larger genetic component and you have a large number of men at different generations that may have gout, then there may be women within that family that have gout. So diet is very important in gout, that there are certain foods that individuals need to avoid because they're not able to process the purines in those foods. So shellfish is one big one, red meat is another, but a number of different foods may be important. Really trying to stay away from a so-called rich diet, the typical alcohol, again, as a major contributor to gout. So rheumatoid arthritis, again, has a genetic component. Like osteoarthritis, we know that it's more common in identical twins than fraternal twins. But there is also Rheumatoid arthritis is one of those diseases that we call multifactorial and polygenic. So there's certain genes that contribute, but it's really a variety. It's not a single gene that contributes. And then there are environmental factors that contribute to it. And same thing in terms of osteoarthritis. Osteoarthritis tends to be much more polygenic in terms of there are many different genes that may contribute to it, and it may be related to different subsets of disease in terms of different phenotypes.
So one of the main concerns coming from patients is the pain that they experience from any type of arthritis. And so let's take talking about the top three that we're discussing. What generates this type of pain? So we know that cartilage, we know that that is aneural, but so where does the pain process start, and for each of those three conditions?
So pain is complex. There are many things that contribute to pain. In gout and in rheumatoid arthritis, the pain is often due to inflammation. So that release of inflammatory mediators can cause release of enzymes that break down tissues and also then can cause pain. What the teaching had been that our cartilage is aneural, but we know now that actually later in disease, there actually is growth of nerve fibers into the cartilage from the bone underneath, or what we call the subchondral bone. The pain in osteoarthritis is still a matter of great research and an interest of ours in terms of what exactly causes it. There may be damage to the tissues, like say in terms of the synovial lining. It may be the subchondral bone that is very much highly innervated. The tissues around the joint capsule, muscles, tendon and ligaments, the meniscus are all highly innervated. And so there's probably multiple different causes of pain. We know now also that there are different types of pain. So there's so-called nociceptive pain, which is pain when there's damage to the tissues locally. And so the most is if you put your hand on a stove and you withdraw quickly because that you may feel the heat and that damage to the tissues in terms of if you keep your hand there too long. But then there's another component called neuropathic pain, which is really related to the nerves. And we know that that also does contribute in osteoarthritis, probably in not early stages, but maybe in later stages. And the spinal cord and the brain also play a role because you can have what's called peripheral sensitization and central sensitization, such that there may not be that much that's causing pain locally, but then it gets amplified. And then, unfortunately, even if the insult isn't there, you may still feel pain. So if you were to, keep touching a hot stove, and it may be later on that you're conditioned that even though the stove may be off, that even just putting your hand close to the stove may cause you to feel pain. And so we know now that there's yet another third type of pain or category of pain called nociplastic pain. And this may be more in terms of individuals with central sensitization, what we call widespread pain, where they may not have nociceptive pain, that there may not be a local insult, and there may not be damage to the nerves or release of compounds in the nerves. So when somebody reports pain in osteoarthritis, it may be a combination of all three of these, and there may be different ones of these types of pain that play a role in different stages of the disease. And so teasing that out is really something that is of great interest, because we would want to understand what type of pain it is to really direct the right treatments in terms of for the right patient that's causing the pain.
So how are these conditions diagnosed?
So it's very much based on questionnaires. There may be questionnaires that are more characterized. So pain may be characterized in many different ways. So severity, oftentimes in terms of on a 0 to 10 scale, or other questionnaires that measure pain severity. Frequency, how often does it occur? Does it occur monthly, daily, weekly? Is it there all the time? Is it there on most days of a month? And then in terms of location, so we've developed a knee pain map saying where within the knee there may be pain, and there's a pain map in terms of which parts of the body maybe patients may have pain. Then there's a pain detect questionnaire in terms of neuropathic pain, or there may be different things that one can do to elicit pain, certainly in terms of palpating a joint. If there's a tenderness that's there, then that may be local problems. And then there's sophisticated tests to identify neuropathic pain. In terms of nociplastic pain, that's a new entity, and so there are questionnaires in terms of looking at more widespread pain. And there's imaging techniques called fMRI or functional MRI in terms of the brain to try to tease out these different pain phenotypes. So there's a lot more that we're learning about pain, and it's a great emphasis of research at the NIH and around the world.
So in regard to rheumatoid arthritis and gout, what sort of testing is done to confirm a diagnosis, or is that, how is that assessed from a clinical standpoint to determine who, has this?
So in rheumatology, the most important test is really the patient's history and physical exam. And so we take the very detailed history in terms of patient's signs and symptoms, and the constellation of those help us determine really most of the time what type of disease the patient has. And then the laboratory tests and imaging and other tests are more confirmatory. Rheumatoid factor is not a good screening test, and so oftentimes there may be physicians that check rheumatoid factor in older individuals that may have bony enlargements of their fingers, and really what they have is osteoarthritis, and checking a rheumatoid factor may be positive because we know that in older individuals they may have positive tests like this, even though they're totally asymptomatic. And so it really is more confirmatory. And then X-ray sometimes can be helpful, but X-ray doesn't necessarily confirm the diagnosis of any of these diseases. There may be typical X-ray findings that one may see in osteoarthritis or rheumatoid arthritis or gout, but that again is confirmatory based on history and physical. For gout, you may have an elevated blood test, uric acid that accumulates in the blood, but the best way to diagnose gout is when you have a swollen joint and putting a needle in the joint and drawing the fluid out and then seeing the crystals under a microscope. One can put a needle into an inflamed joint or a joint swelling in rheumatoid arthritis and osteoarthritis, and there may be, again, some typical findings, not necessarily diagnostic, but findings that may be consistent more with a very inflammatory process, or in osteoarthritis, it may be not greatly inflammatory, but not normal.
So we know that treatment for pain, has certainly changed over your career. And so looking at what you would take a patient through in regard to a typical osteoarthritis patient that is experiencing joint pain, you've evaluated their pain. What are the different levels of pain management treatment that you typically prescribe?
So really the goals of management are to reduce the pain, not necessarily eliminate it because we can't necessarily eliminate, and also to preserve function and avoid disability. So really the first mainstay of treatment is education in terms of understanding what arthritis is and what potential causes are and what things may or may not make it worse, and in terms of staying active and mobile. People think that having arthritis, you shouldn't exercise. Certainly if your joints are red hot and swollen, you should try to reduce using them. But again, as I mentioned, you want to keep them active. And then the second stage is really what we call a non-pharmacologic management. And so that may be physical therapy or occupational therapy or use of certain devices, assistive devices, splints, canes, and those can be very useful. Exercise, particularly prescribed exercise by physical therapists and occupational therapists, and also instruction in joint protection techniques are very useful. And then after that, what we can use is analgesic. So acetaminophen may be helpful. Use it now and then for acute flares. And unfortunately, we really don't have good medicines to treat pain in general, but particularly in osteoarthritis right now, because they have many side effects and they may not be that potent. And so it's really a balance of risks and benefits. We know that non-steroidal anti-inflammatory drugs or NSAIDs may be helpful. Over the counter, you can buy ibuprofen or naproxen. But again, they have side effects, particularly in higher doses, particularly in individuals that are older, can cause GI upset, can cause cognitive problems, can cause problems with salt and water retention, can raise blood pressure. So there are many side effects to NSAIDs, although they can be useful when used under a doctor's guidance. And those are really, right now, the proven treatments. There are many other treatments. Many studies of supplements have been done. Unfortunately, they really haven't shown to be of a great benefit in randomized controlled trials. Some individuals may see some benefit from some of these supplements, but overall, for the larger general population, they haven't shown to be of benefit, a greater benefit than, let's say, placebo. So there's a lot of research going on to try to find newer and better treatments for osteoarthritis. And the problem is we don't have what's so-called a DMOD, or a disease-modifying osteoarthritis drug that's been approved by the FDA or the EMA, the FDA equivalent, the European Medical Agency, that would either slow or stop the progression of osteoarthritis. So a number of drugs have been studied, and unfortunately, those trials have been negative for a variety of reasons. There's still quite a number under development. So
before we move on to discuss treatments for rheumatoid arthritis and gout, can you tell us about stem cell and PRP treatment for osteoarthritis? We hear a lot about it, know a lot of people who have tried it. Where is that currently?
So there's a lot of interest in stem cells and PRP. We know that none of these treatments are FDA approved currently for osteoarthritis or orthopedic conditions, although they may be used for it. There's some intriguing basic science studies that would suggest that it may be of benefit, potentially some animal studies. But the randomized controlled trials, many of them have been, shall we say, underwhelming in terms of results. And these are done by individuals experienced and in good centers. It's not easy to do good studies of these treatments, and very rarely are they compared to placebo. They may be compared to other treatments that may or may not have benefit. The challenge on both PRP and stem cells are that since they're not FDA approved, you really don't know what you're getting. And so the idea is that PRP should, or what's called platelet-rich plasma, is that you're taking blood out, you're circulating it, you're removing other components in terms of red cells and white cells, that you're enriching the platelets and all sorts of different other chemicals, potentially growth factors or anti-inflammatory products within the preparation. But you don't know what you're getting. And there are also bad actors and other chemicals that are pro-inflammatory or proteolytic enzymes within that. And so are you getting only the good chemicals and not the bad ones? And even worse, you don't really know how much you're getting. And so in some very well-designed studies, they looked at in terms of the biologic potency and exactly how much platelet-rich in terms of meeting those definitions when they administered it, and that didn't show any greater benefit in osteoarthritis than placebo. The same thing in terms of stem cells. So stem cells may come from various different sources. It may be from umbilical cord, it may be derived from fat, it may be derived from regular cells that are then transformed. And again, the dose in terms of how much you're given, in terms of whether these stem cells can really transform. The difficulty is that the stem cells right? They don't necessarily go where you think they're going. And if you're infusing them and then are they going to be smart enough to go to your joints? And then when they're in your joints, are they smart enough to do the things they're supposed to do and differentiate into damaged tissue such as cartilage or bone? Or would they differentiate into something else? And so there have been reports of people that have undergone stem cell therapy and had tumors or growths in other places and other side effects. And so again, these are really not well regulated. And so people have to be very careful. There are studies ongoing. And so in the caveat would be they really should be only studied in clinical trials at this point, since they're not FDA approved. And generally in a clinical trial, we'll pay people a small amount to participate. And if you're being asked to pay $3,000 or $5,000 or $10,000 to participate in a clinical trial of an experimental treatment, then you should really walk or run away as fast as possible.
So you have been, in speaking with patients, expressed a very positive outlook on treatments for rheumatoid arthritis. And if you can tell us, it seems to be a new era in treatment for RA and what advancements have been made.
Well, when I first started early in my training, we had very limited options for rheumatoid arthritis. And some of those we don't use anymore. And so the trainees and fellows and junior faculty have never heard of or never used intramuscular gold, which was really the mainstay of treatment. We used methotrexate, but in lower doses and only by itself. And so methotrexate is a chemotherapeutic that's used in cancer, but we use it in lower doses. And we also combine it with other treatments. Really, the dramatic change in rheumatoid arthritis has been due to advances in basic science, which identified a compound, tumor necrosis factor, that's produced in cancer cells, but also in rheumatoid arthritis in terms of in the pathways of inflammation. And in 1998, there were new drugs that were approved for the treatment of rheumatoid arthritis. And that essentially has revolutionized the treatment of rheumatoid arthritis, so-called biologics or biologic response modifiers. And now we have quite a number of drugs, biologics that aren't just tumor necrosis factor inhibitors, but also other so-called biologics that are manufactured molecules in terms of antibodies towards specific targets like tumor necrosis factor. And they've really revolutionized the treatment of rheumatoid arthritis, psoriasis, psoriatic arthritis, inflammatory bowel disease. We have some of those for lupus, but those are really not as, shall we say, as good as we have for rheumatoid arthritis at the moment. Unfortunately, there's an explosion of research in lupus, so that there are many new treatments being investigated. And so I think in a number of years, we'll see a dawn of a new era in lupus. And as I mentioned, there are also a number of biologics and other treatments are being investigated for osteoarthritis. So hopefully we'll have new treatments, for many diseases over the course of my career, certainly scleroderma in terms of inflammatory myositis, even gout. We have some other treatments now.
Is remission possible for a patient with rheumatoid arthritis?
Certainly it is. We don't see remission a large amount of time, but certainly remission is possible. And what we try to achieve now is low disease activity. And so it's really the balancing of risks and benefits. And so in terms of, rheumatoid arthritis is a autoimmune disease. And what I tell patients is that your immune system, which is very important, and we've learned a lot about your immune system during the COVID pandemic, is very important in terms of fighting outside invaders, viruses, bacteria, but also as a monitoring system for cancer. But unfortunately, in rheumatoid arthritis and in lupus and other rheumatic diseases, so-called autoimmune diseases, your immune system gets confused, and instead of fighting outside invaders, attacks your body and attacks your body in certain ways. And so we have to dampen down the immune system. And so it's a balance of when we dampen down the immune system, that can also put you at risk for future cancers, or particularly in terms of certain infections. And so it's a balance of tamping it down enough to control the disease, but not so much to then have you be at greater risk for infections or cancers down the line. And so each drug has that difference of risks and benefits. And so we're still trying to have more research in terms of both effective drugs that are more effective, but also drugs that are safer and have less side effects. I think importantly, as I tell patients, there are no safe drugs. All drugs have side effects, and just because something's natural doesn't mean it's safe. Poison ivy is very natural, and so there are a number of other compounds right in nature that are natural and certainly not safe, and so one has to be careful about supplements, or even water one thinks should be fairly safe and benign, but if you drink too much water, that's also not good for you. So certainly a balance and moderation is important.
So we've talked about treatments for osteoarthritis and for rheumatoid arthritis. Where is the treatment for gout, and what have you seen as far as improved treatments?
Well, gout is certainly avoidance of certain foods, particularly shellfish, red meat, alcohol. The treatments for gout that I grew up with as a young physician are still what we use today in terms of allopurinol. We just know how to use it better. And so for patients that can't tolerate allopurinol, there are newer treatments that are like allopurinol, febuxostat, that again address the metabolic abnormalities that one sees in gout. And so again, some of these have various side effects. And so there's, again, research being done to try to find drugs that may be similar or work in different ways that may be effective and have less side effects.
So we've learned a lot today about the three most common forms of arthritis. So say someone suspects they may have one of these conditions. What is their first course of action?
So their first course of action should be really talking to their physician or their healthcare provider in terms of these symptoms. So oftentimes the first symptom is pain, or if people have red hot swollen joints, or they may have a rash or other manifestations. I mean, one can search the internet, but one has to be careful, because both in terms of misinformation on the internet, but also sometimes a little bit of knowledge may be dangerous in that there may be symptoms that are common to many diseases and are not specific. And so it may seem like, oh, I have A, B, C, and D, and so I must have one of these diseases, but this is something that's very common. And so, for example, having a rash or having a headache, and many people have those. So just because one has a headache doesn't mean one has a disease, but it may be a certain type of headache, but then also in relationship to other symptoms that may have a doctor say that. Some of these are rare, and so certainly the physicians, particularly in primary care, may not have encountered very many of those in their career. And in that case, patients may need to do a little more digging or else in terms of seeing a specialist.
So we've talked about a number of wide-ranging topics today. And one thing before we wrap up today, one thing that we would like to have the opportunity to talk about is research. And your primary area of research is osteoarthritis, knee osteoarthritis in particular, and the early detection of that. And if we can, as we wrap up today's episode, if you could share with us a little bit about where your research is now with knee OA and what people can expect to see in the future.
So I've been fortunate to be involved in the Osteoarthritis Initiative, a public-private partnership that was funded by the NIH over 20 years ago now. And that has really provided a resource not only for myself, but for investigators around the world in terms of osteoarthritis, particularly knee osteoarthritis, but also hip and hand osteoarthritis. And it taught us a lot about pain and imaging in terms of X-ray and MRI. We're still learning more in terms of how we can interrogate X-rays and MRI and use artificial intelligence to help us understand more what we're seeing there and how to then pull out that information. We've learned about the different components and potentially different phenotypes of osteoarthritis, potentially then better characterizing individuals, again, from a research perspective, not yet ready for prime time clinically, but hopefully in the future in terms of targeting particular subsets or phenotypes of disease. And that's certainly helped pharma companies that are developing drugs in terms of thinking about designing trials, in terms of studying the efficacy of different compounds that may be beneficial in osteoarthritis. And so there's still a lot to be learned, but we've learned quite a bit about different risk factors. We're learning more about pain and how different types of pain may contribute and how there may be different abnormalities on MRI that may contribute to pain in osteoarthritis. There's still more work to be done, but fortunately, with the osteoarthritis as a public-private partnership with a resource that's public available, really researchers all over the world have been able to utilize this. And so it's really helped in our advancement of our knowledge of both how this disease starts and what some of the underlying risk factors and pathogenesis, and also how it progresses.
So we've been joined today in the Joint Space podcast by Dr. Kent Kwoh. Thank you for joining us today, Dr. Kwoh.
Well, thank you. It's been an honor and privilege to be here and sharing the time with you.
Thank you again. Joint Space, where people, ideas, science, action, and curiosity come together. The Joint Space podcast is brought to you by the University of Arizona Arthritis Center. To learn more about the Arthritis Center, please visit arthritis.arizona.edu. We appreciate your interest in this show and our Living Healthy with Arthritis programs. If you enjoyed this episode, please give us a like and subscribe to our podcast on your favorite platform. Joint Space is produced by Greg Gillis with assistance from Luke Brower. Graphics were created by Luke Padway. Our theme music is courtesy of MC Yogi and John Pattern. Thank you for listening. Every step counts toward better joint health.